And we're going to be carrying this theme forward about health disparities in emergency care within medics specifically. And, Dr. Khaldun really set up the topic well for us to carry it forward with the next two speakers. We're going to be hearing from two graduate students who are interns with Medic this summer. I'll talk about them and introduce them in a bit here, but just want to reset a little bit on Medic's work in this field in the last year. We started, recognizing that Medic really has, an opportunity to use its platform to dig deeper into this problem starting last summer. And what we ended up doing was putting together a work group with volunteers from you out there in the audience. The goal of that work group was really to understand, what are the potential key activities, how to measure potential impact around those activities, and then setting up a course of action with some shorter things as well as long-term goals here. And a lot of that, we began to recognize exactly many of the things that Dr. Khaldun was describing, which is, you really have to understand the quality of the social demographic data that we collect within the registry before we can begin to reliably report out on performance, stratifying on things like race and ethnicity. Before we can then begin to really address those gaps in care that we discover. So for that reason, we took a deeper dive into how that data is collected and relied on our summer interns to help with that work. So we're going to hear first from Timberlee Whiteus. She's a master's student in School of Public Health here at University of Michigan. And she's going to talk a bit about what her work was, and we'll have an opportunity to do some questions. So similar to what we always do with external speakers, use that Q&A function to input some questions. And then after that, we'll hear from Sarah El-Azab, who is a PhD candidate in the School of Public Health, also here at the University of Michigan. And she'll be talking about her work. And then again, we'll have an opportunity for some question and answer period after that. Okay, so I'm going to hand the podium off here to Timberlee. The camera is all yours.
Hi, everyone. Like you said, I'm Timberlee. I am an MPH candidate studying health behavior and health education. I had the pleasure this past summer to combine my interest in exploring health disparities and work with Medic, and continuing that work now to understand ED point of care and patient demographic data collection. So to start us off, there's research out there that says patients are predisposed to and currently endure social situations that affect their health outcomes. Given that data, our project goes through qualitative interviews with adult and emergency registration staff. We wanted to, one, understand how that patient demographic information was assigned and collected and reported in the EHR, and then also understand the roles and responsibilities of the staff and then the patients and caregivers in assigning that and reporting that information. And then also we wanted to understand the process for which patients can change their assignments in the EHR. And so when I'm referring to patient demographic information, I mean like race and ethnicity, preferred language, gender identity, sex assigned at birth. So those sorts of things. Given our goals there, we created an interview guide and conducted pilot interviews with 2 adult and emergency pediatric registration staff. The interview guide gauged 3 of the following areas: training for the registrar role and typical task, the process for patient demographic data collection, and then patient interaction and rapport. So when we gauged those with those 2 staff, we found the following. That registrars are trained holistically. There are no typical shifts. They're given a script, and they did say the script might have been code, so they're allowed to deviate from it as long as they're eliciting the information that's needed. In regard to patient demographic data collection, demographic information is most accessible to staff. So seeing that information and being able to pick from it, they deem that most accessible to staff and not patients. with the ability to change that demographic information. So to change it, maybe change your race, change your ethnicity, change your address, etc., it's most accessible to staff and patients. In regard to patient interaction and rapport, we found that actually patients are most likely to share demographic information if they understand why it's being collected and like how it will be used. And then if they're informed on who gets access to that information. So that's something that patients deem really important when reporting like sensitive demographic information. There were two major takeaways from the research done this summer. The first one being that there is some variation in the way in which demographic data collection is like happening at these sites. There was a various like report and comfortability levels. So that comfort level was really attributed to the time in which a registrar spent in the role, and then also personal beliefs and values of the registrar. Another thing was the provided reasoning for collection is often modified. So if a patient asks, why are you collecting my religion? One registrar might say, this is required by the government, while another might say, this is going to affect the level of care so that we can hopefully receive optimal health outcomes. The next takeaway was not all data is reported in the way in which it's collected. So there's a lot of perception versus misperception. So if someone is asked their ethnicity and they report white, which is usually listed under race, a registrar might assume an ethnicity of non-Hispanic. And also there's a difference with adult and pediatric patients. So pediatric patients, of course, the registrars have to receive the information from the guardian or a parent who is present at the time. And so if a pediatric patient were to say, a male presenting, I don't identify as a male. If the patient's parent or guardian says like, oh, this is a male, then the registrar will have to listen to them. And so that's something that was also noticed in that. Okay, given those takeaways, I'm like, any questions here?
All right, so we have a couple of questions. What was the most
So I think the most surprising thing that I found was one, I would say the honesty among the registrars, because I didn't expect anyone to report that they would make assumptions in this space. And then I've also, a registrar did report that there had been mistakes previously in reported race within a patient's EHR. And I think that's really important information because these are things that we do use to treat patients such as religion. And I think it's really important that we get those rights. And so I guess that's probably the most surprising thing that I found.
And then one more. What was the biggest barrier that the registrars identified?
So the biggest barriers it seemed that the registrars really identified would be hesitancy among patients, and they kind of mentioned literacy a bit in there and the patients not really understanding why information is collected. And I think a lot of that goes back to like trust within the health system, between patients and the health system, and understanding that you're collecting this information to, like I said, hopefully we can receive optimal health outcomes in this. And so that was the biggest barrier, was like that hesitancy among patients in reporting. One more. Sorry.
What changes would you suggest going forward?
Moving forward, I think it's important to create a standard practice. It seems like a lot of work needs to be done in the organizational like development realm, kind of just making sure that as time goes on and as registrars become more comfortable in this role, that they also adhere to a standard of not assuming, of maintaining that respect of just those standard rules that they received when they first began. So I think moving forward, a lot of organizational development needs to be done in also a lot of work in identifying practices across the board and seeing, is there a standard? Does a standard even exist? Okay, and now I'll be passing over to Sarah.
Hello, everyone. I'm Sarah El-Azab. I'm a PhD student in the Department of Health Management and Policy, where my research is really centered on health information technology and associated policy, specifically really interested in EHR demographic data quality. So this summer, I really focused on looking at the data in terms of how it's collected within the EHRs and then how that's mapped to the MEDIC data. So first of all, just as some background, their electronic health records data is messy. There's a number of data quality issues that can arise, including completeness, consistency, accuracy, and timeliness. And when it comes to demographic data, as Timberlee noted, there can be differences in how people are reporting their data to whoever's collecting it, and then how it's actually entered into the EHR. And it's really important to address these data quality issues with demographic data specifically because it's often used to assess health disparities, identify inequities. And in the case of MEDIC, which is collecting data from numerous different EHRs, it's even more important to understand what's going on behind the scenes. So the first thing I wanted to take a look at this summer was how MEDIC is collecting demographic data. So what the categories are in the MEDIC data dictionary, and then sort of what the overall quality of the data is. So first, I took a look at race and ethnicity data. MEDIC collects the standard categories like in alignment with like the NIH and the Office of Management and Budget. So these white, Black or African American, some other race, Asian, multiracial, more than one race, American Indian, and then Native Hawaiian or Pacific Islander. MEDIC has really good quality of data overall, so there's very few missing values in this data set, and then there's only about 1.52% of the data has conflicting values. And when I took a look at this a little closer, it appeared to be primarily with the patients that were either some other race or more than one race. So there seems to be a little bit of mismatch in how some people are collecting that and reporting it. Similarly, I took a look at ethnicity. MEDIC collects whether or not patients are Hispanic or Latinx or not. And so similarly, very high rates of data completeness and even fewer rates of any sort of conflicting values. Finally, I took a look at gender. MEDIC collects female, male, or other or unknown. And there's pretty much no missing data when it came to this category and very few conflicting values. So with this in mind, I wanted to understand how the sites were then mapping their own data to the MEDIC data dictionary. So over the summer, I contacted the IT folks at the various MEDIC sites and asked them for a list of all of the gender, race, and ethnicity categories that are being collected in their EHR. And then I asked how these categories are being mapped to the MEDIC data dictionary. So whether it was in code or if they had a mapping table, I just wanted to see how things were being lined up and matched. So when it came to race and ethnicity, the primary takeaway was that there was a lot of variation in how race and ethnicity are being collected across MEDIC sites. In fact, no two sites were collecting this data in the exact same way. So first of all, a lot of sites, there were very big differences in terms of granularity. So some sites were collecting very specific country of origin or like ethnic background data, very granular, or would collect the specific categories if someone reported that they were multiracial. And so while other sites more closely aligned with the OMB and NIH standards of demographic data collection. Similarly, definitions of race and ethnicity were not consistent. So there were some sites that collected things that are typically thought of as ethnicity, so Hispanic or Latinx, you'd find them in the race data and vice versa. And then this was also the case for Arab and Middle Eastern, which is a kind of tricky category. Typically, it's folded under the larger white category, even though this is a very distinct population with very specific needs. MEDIC sites are collecting data on Arab and Middle Eastern patients, but some sites are classifying it as race, some as ethnicity. And so it's really interesting to kind of see some of those differences. Additionally, there were some outdated terms that were being used in some of the data collection. And then finally, not all of the sites were mapping the data in the same way. So take, for instance, if a patient if they were unknown, some sites wouldn't map that data, some sites would map it to some other race. So I wanted to give you an example of what this might look like. So these are two institutions that I collected data from. And as you can see, looking at comparing the race and ethnicity fields, there's a lot of difference. One site has far more granular ethnicity data. The other site has far more granular race data. When it came to sex and gender, it was collected relatively consistently across the sites. But there were some sites that were collecting data on non-binary patients within the sex and gender field. And there were also some sites that were collecting gender identity separately from sex. So finally, I was able to offer some recommendations to MEDIC based off of this work. So my first recommendation would be to collect and audit the demographic fields and the mapping from the MEDIC sites annually. This is just because there's a lot of change that happens as this data is being collected over time. Some sites kind of change how they're doing things. So for example, Michigan Medicine is currently undergoing some changes in how they're collecting race and ethnicity data. So it's important for MEDIC to understand what these changes are and how they translate to the MEDIC data dictionary. Additionally, I recommend phasing in some gender identity data since sites are starting to collect that separately from sex. Additionally, I would recommend adding Arab or Middle Eastern to the MEDIC data dictionary since this is such a big population here in Michigan. There's still a little bit of discussion needed to determine whether it should be collected as race or ethnicity, but at the very least, adding it to the dictionary in some way. And then finally, adding unknown or missing categories to the MEDIC data dictionary would help in cases where some sites aren't sure how to map that data. So whether they're not mapping it or mapping it to some other race would be helpful. And then this is more of like a long-term suggestion, but it would be helpful to maybe just collect the data directly from the MEDIC sites and do the mapping internally. So with that in mind, that's pretty much it for me.
Okay, so we do have a couple of questions for you. First question comes from the audience. Did you notice any major differences between the types of EMARs or the electronic health records, Cerner, Epic, and how they collected the data, and specifically related to non-conventional gender identities?
Okay, so I was only able to collect data from, I think, one Cerner site. The rest of the sites were Epic sites. So it didn't really give me the best form of comparison, but my understanding and from what I saw was that there was a lot more granularity and I think customizability in the Epic EHRs. I think this is a feature of Epic when it's being implemented at a site. There's a lot of customization that the sites can do. So I did notice it in terms of race and ethnicity. I would need to take another look in terms of gender identity.
Okay, one more for you. What do you think is the ideal approach for recording socio-demographic information for patients?
So that's a really good question. I think it would be really good to make sure that this is something that's reviewed pretty frequently. So just making sure that when a patient comes in, every time that they come in, that's something that's being checked and verified with the patient, particularly since we want to make sure that this is as close to their self-report as possible. So I think taking greater care in how the interaction, so going back to Timberlee's work as well, so paying attention to some of those discrepancies between how patients are reporting their data and then how it's being translated into the EHR. I think that's a really good first step in making sure this data is collected in a really good way. All right. So I'm going to hand it off to Keith.
Thank you, Timberlee. Thank you, Sarah. It's not easy being in front of a camera. You guys were awesome. And thanks so much for your work. I'm going to summarize a little bit too from the Corning Center's perspective on how we're taking next steps based on what we're discovering here, in particular from the summer work. As you can tell, getting at reliable and accurate information in the medic registry really operates on two levels. As Sarah was describing, there's this macro level of understanding how the medic data dictionary is mapped to the electronic health records at all of our hospitals, how that mapping happens, and ensuring that it's consistent and standardized. So we'll be working through that process iteratively. And then really at the micro level, as Timberlee was describing, and this, operates probably at a level that is harder for medic to influence, but understanding really at the point of care, in the emergency department itself, how this data is collected. And my bet is that process is wildly variable at all of your emergency departments, that it is owned by a large variety of people and jobs and roles. Timberlee was calling out registrars in particular. That's one site's version, but my bet is that this occurs in a number of ways and probably inconsistently at times too. And, I think that's something that we're all going to have to reckon with, not just within the state, within Michigan, within medic, but very broadly, emergency departments across the nation. And frankly, it's a problem for healthcare delivery, generally speaking. So we're going to be mindful of all these things, as we work to get to a point where we have reliable information. Sounds like a lot of it is fortunately available to begin with the interest of being able to then report performance stratified, by these variables to understand where our gaps are and how to close those gaps. So at the end of the day, more to come from us.